Dr. Minnaar. So I'm very happy with Professor Minnaar to be here today because she's a very important person always in my life regarding hyperthermia, so I'm happy to have her here. So she is going to speak about 4 case reports on complex high-risk sarcoma cases treated with modulated electro-hyperthermia. Okay, Dr. Minnaar, you are welcome.
Hello, Dr. Arjo. How are you? Here we go. Can you hear me?
Yes.
Oh, there we go. There we go. Okay, first I would like to say thank you very much for the opportunity to be here. And congratulations on organizing this. It's not easy to take a large conference and put it on a digital platform under short notice. So yeah, thank you. And also it's fantastic to see everybody else here. Nice to see you all, and I hope that everyone is relatively unscathed from the traumas of the past year. Okay, so as Dr. Arjo said earlier in the meeting, it's been difficult to conduct clinical trials at the moment. We had, during our lockdown, the hospital was closed except for essential services. So we were treating essential patients, but clinical trials were stopped. So we have a few studies that we are busy with, and unfortunately, we don't have great preliminary information to present today on the studies. We do have, I think you may all be aware of this cervical cancer study. We are presenting the 2-year results at ESTRO at the end of the month. So I hope maybe some of you will be there to see that. Today, we have in our department, or in our hospital, one of the top orthopedic surgeons, and he works a lot with sarcoma patients. So he's been referring some very interesting patients to us. So we thought for today we would present some case studies of patients that had some very unique characteristics and how we navigated around them. And so all the patients are, why is it not going to the next slide? There we go, it's a bit slow. So all the patients I'm presenting today are sarcoma patients. As I think everyone is aware, sarcomas are quite rare tumors, less than 1% in adults and 15% in pediatric cancers. One of the characteristics of sarcoma patients that makes them so difficult to treat is that we have over 100 unique subtypes. And the management needs a multidisciplinary team, including surgery, radiation, chemotherapy, and often rehabilitation and long-term following and management afterwards. Now, there are very clear and detailed guidelines internationally, which aren't always able to be extrapolated and applied in a resource-constrained setting. Perhaps you're aware, up until the end of last year, I was based in one of our state hospitals, which is quite resource-constrained. Fortunately, as of this year, I've moved to a private hospital, and here, unlike I think in Europe, here our private hospitals have better facilities than the state hospitals. So we now have access to all the great planning and radiation techniques from mEHT, VMAT, stereo. So yeah, we can treat our patients quite well in the facility that I'm in at the moment. Unfortunately, the patients do have to pay for the treatment, so the insurance is quite expensive, so cost is always a factor still. So ESMO mentions hypothermia in their guidelines for the management of high-risk soft tissue sarcomas. The indications according to the ESMO guidelines are irresectable, locally advanced, deep high-risk soft tissue sarcomas that are more than 5 centimeters in grade 2 or 3. The hypothermia could also be indicated in patients wanting to attempt limb-preserving surgery, and for metastatic and recurrent tumors that have been previously treated. So a lot of our patients that we are managing in a private setting are retreatment patients, patients where there are very limited options. And as it has already been said in the meeting today, retreating with radiotherapy is often very challenging depending on the time between the recurrence. Okay. So a quick literature search shows 2 studies on the management of sarcomas and combined with chemotherapy and hypothermia. Perhaps you're all aware of Essel's and his team studies. It's 2 papers. One was the original study, and then the second paper was a 10-year follow-up. Both with really good results, and this was referenced quite significantly in the ESMO guidelines. So it was a large group of participants, 309 participants, treated either with or without hypothermia. And as you can see, the results on the slide were quite, well, almost all significant, except for the 10-year survival, which was better in the hypothermia group, but didn't have a significance. Median survival was 15.5 years versus 6.2 years, so that's it's more than double. And what's also impressive is the medium time to local progression. So that's one of the challenges with sarcoma patients, is a poor quality of life. And if we can delay the progression and improve local response and disease-free survival, that would obviously be the best end goal. Okay, so 2 small studies that we could find in the literature investigated hypothermia and radiotherapy. One was a phase 2 study, but a fairly old one, 1989. And that was conducted by Leopold and his group. And in the study, 17 participants were treated with hypothermia and neoadjuvant radiotherapy. And then after surgical excision, the histopathological regression in hypothermia was more when hypothermia was administered twice a week versus once a week. So based on this study, we applied protocols of administering hypothermia twice a week rather than once a week during radiotherapy. Then another retrospective study of radiation-associated sarcomas of the thorax. There were 16 participants. They were female prior breast cancer patients, and then they had a recurrence or a radiation-associated sarcoma in a previously irradiated area. So these patients were treated either with the AMC or the BVI protocol. For those who aren't familiar, these protocols were developed, as far as I know, for breast cancer, for treating recurrent chest wall tumors in patients who've been treated for breast cancer. The AMC protocol, both protocols are hypofractionated. The AMC applies 4 grays 8 times, twice per week, and the BVI applies 3 grays 12 times, 4 per week. The results in a comparative analysis of the 2 studies, the results were similar, with the only exception that the AMC protocol had a few more side effects. So the toxicity was a little bit higher in the AMC protocol. Then one study, a more recent study, looked at triple therapy, so radiation, hypothermia, and chemotherapy. And this was the only study to administer hypothermia using capacitive devices. This one used an 8 megahertz radiofrequency capacitive device. And it was conducted in Japan, sample size of 60 participants. And these patients, the outcome was retrospective, well, was compared to the bone and soft tissue tumor registry in Japan. In this study, although overall survival was not significantly different between the 2 groups, local control was significantly improved, and there was a higher 5-year local control rate in the hypothermia group. And importantly, in the patients who received hypothermia, amputation was averted or not as common. And again, this speaks towards the quality of life that we're ultimately trying to achieve, not only just the quantity. Okay, so we use a capacitive heating technology called modulated electro-hyperthermia or Oncotherm. The device uses 13.56 megahertz radio frequency generated between 2 electrodes. I think everyone is fairly familiar with this. The modulation on this device is believed to be the main difference between this and the other capacitive heating technologies. And the modulation allows for a more effective treatment in comparison, which means that we can have a lower power output and a lower temperature, and we have better safety. So because we're using modulated electro-hyperthermia, we did a search for studies on sarcomas and the type of treatment that we're using. We couldn't find any published phase 2 or phase 3 studies, but we did find some nice case studies. This case study was reported in 2013. The patient had a synovial sarcoma, a 48-year-old female, and the sarcoma was in the right thigh. She was treated surgically in 2004, and in 2011 she presented with lung metastases. These were treated with radiotherapy, but she only had a partial regression, and modulated electro-hyperthermia was then administered as a monotherapy. So 39 treatments were given over a period of 6 months, and she had a partial response to that as well. Okay, then this paper reports on a series of 13 cases, all sarcoma patients treated with modulated electro-hyperthermia. This was published in the Case Reports in Clinical Medicine in 2015. The patients were between 18 and 73 years old, 6 male, 7 female, and included primary and recurrent sarcomas. A variety of histological subtypes, which you can see there. And the treatments were quite broad, involving either radiotherapy plus modulated electro-hyperthermia post-op, or as a primary treatment. And 1 patient received chemotherapy as well. So it's a very diverse group of patients. Interesting paper if you're interested to read it. But in summary, all patients showed either stable disease or partial regression. Right, so we looked at our sarcoma patients. As I mentioned, we are receiving quite a few. And based on this literature review, we are now considering starting further investigations or a study on modulated electro-hyperthermia and radiation for sarcoma patients, but we're still toying with the idea. So the objectives here were to assess our patients and to assess if the addition of mEHT would be affordable and practical in our setting. As I said, we looked at our patient history over the last 2 years, and we're reporting on the patients that we've treated with sarcomas in the private facility only. So the first patient was very interesting. She, in 2014, was diagnosed with a synovial tumor, sarcoma of the heart valve. She had no disease anywhere else, and as a result, the team managing her at the start of her diagnosis recommended that she undergo a heart transplant, which she did successfully, and a pacemaker was inserted. And obviously, having had an organ transplant, she was prescribed chronic immunosuppressant medication. The heart was functioning very well after 6 months, and so although they left the pacemaker in, it was deactivated. In 2015, just over a year later, the patient presented with multiple pulmonary nodules, and these were treated with radioablation. Unfortunately, 3 years later, there were more nodules and revealed progressive disease. She had pulmonary nodules as well as subcarenal and mediastinal lymphadenopathy. Chemotherapy, unfortunately, was not an option for this patient, being on immunosuppressant medication, and radiation was possible, but she had to be carefully planned because of the pacemaker and the heart. All right, in an attempt to try and further analyze the tumors to determine the best treatments, she underwent gene sequencing, but there were no relevant mutations, and she was PD-L1 negative. Okay, so this patient was prescribed external beam radiation. She had 33 fractions in 2 grays. She received modulated electro-hyperthermia, excuse me, twice a week, so a total of 14 treatments. We used a 20 centimeter electrode, and modulation was turned on from the 3rd session. We were most concerned about the heart being in the treatment field. So we started at a power of 45 watts and increased to 90 watts over 5 sessions. We made sure that the deactivated pacemaker was outside of the safety margin and the treatment field. So using the 20 centimeter electrode, the safety margin is a 10 centimeter radius from the electrode. Unfortunately, with this patient, the follow-up scan didn't reveal a response, but the disease was stable. So this was, although disappointing for the patient at the time, considering the aggressiveness of the tumors and how quickly the disease had progressed prior to starting treatment, we felt it was positive. In any case, the patient was naturally a bit demotivated. She had been training to, there is an organ transplant Olympics, I think, or championships, and she was planning to attend that at the end of last year, which she then was not able to do. But her follow-up now, more recently at 18 months post-treatment, showed that the disease is still stable. So this is a definite win and definitely improved the patient's morale. What's very important is that she is completely asymptomatic and she's living an excellent quality of life. So she is quite happy now. Okay, I've included this, the planning images, so that you can see in this field the distance between the pacemaker and the treatment field. Okay. And our second patient is a 68-year-old male. He was diagnosed in 2015 with a myxoid sarcoma in the right thigh. In 2015, it was a very large tumor, 21 by 15 by 10 centimeters. It was surgically excised, and this was followed by external beam radiation. He had 33 fractions of 2 grays and completed treatment early in 2016. Unfortunately, the tumor recurred, and this was followed by another surgery. In 2018, the tumor had recurred again. This time, the tumor was 30 centimeters and inoperable. At this point, the tumor had extended into the pelvic cavity and was compressing the bladder and the rectum. He had bilateral hydronephrosis as a result and difficulty with bowel and bladder function. Because of the bilateral hydronephrosis, he wasn't eligible for any further chemotherapy. There also was a concern about administering more radiotherapy in case he needed an emergency operation in the area. The tumor was in the anterior medial part of the right thigh, and the femoral vessels were involved. So there were concerns by the surgeon that he would have to perhaps undergo an emergency operation. So we thought, in the absence of any other options for this patient, we administered modulated electro-hyperthermia as a monotherapy. We gave this twice a week for 3 months. We had to use the 30 centimeter electrode, obviously, with the tumor being so large. And after 3 months, another scan revealed that the disease was stable, but the hydronephrosis and bladder and bowel compression had reduced. As a result, the patient was now eligible for chemotherapy. So the medical oncologist consulted, decided to put him on 6 cycles of Calyx administered every 3 weeks. We continued with this and modulated electro-hyperthermia twice a week, and a follow-up scan after 6 months showed complete resolution of the bilateral hydronephrosis and a significant resolution of the pelvic portion of the tumor, which meant at this point that the patient's bladder and rectal function had also returned to normal. The patient was in a wheelchair when he first presented. He remained in a wheelchair for the rest of the time, but as time progressed, he gained more movement. He was able to stand up and then sit onto the bed rather than being helped onto the bed or just using his arms.
Sorry, Carrie, you are almost 20 minutes, so please, sorry for that, but we need to go a little bit faster. Thank you.
Yes, sure, thanks. So this patient, we prescribed another round, and after 6 months, the disease was still stable. Unfortunately, the patient is deceased. He had a wound in his foot and died of septicemia. Okay, you can see the size of the tumor there. This patient, she had a squamous cell carcinoma of the left maxilla. She was irradiated and had a recurrence, but it was a radiation-associated tumor. She was retreated with radiation combined with modulated electro-hyperthermia. The tumor didn't respond, but there were no unwanted side effects, and the patient tolerated the treatment very well. So there you can see the invasion. And then the final patient is still undergoing treatment. He's had brachytherapy 4 times and irradiation. He had a dermatofibrous sarcoma in the right clavicle. He's currently undergoing his 2nd round of radiation and finished yesterday with no skin toxicities combined with hypothermia. So that's quite interesting for us. So to summarize, what we found is that we thankfully were able to treat a patient safely with a transplanted organ in the treatment field, that the deactivated pacemaker didn't get hot or cause damage, and that combining modulated electro-hypothermia with reirradiation did not cause any further adverse events. And that this is a suitable potential for the chronic management of patients who are inoperable and don't have any further treatment options. So we are, as I said earlier, considering investigating another study, developing another study, investigating radiation combined with modulated electro-hypothermia. And then finally, I'd just like to acknowledge the surgeon, Dr. Richard Kite, and the planning team who assisted with the images and all the patients who gave permission for us to present their data. Okay, thank you everyone for your attention. Sorry, I apologize that it went over. I had my timer on, but my phone went off. So I apologize for that.
Thank you, Carrie. Very interesting. I just going to say Professor Bodis, he has a little comment. So if you are very fast, maybe we can comment that, move forward.
Thank you, Elizabeth. Yes, I will be very fast. Congratulations for all speakers. I think what you lined out is an excellent path of research, of joint research, I think for all involved disciplines. And I think both presentations were very helpful for this. I would just be careful at the moment to use modulated electro-hypothermia alone for patient care, unless we can better document the thermal effect of hypothermia and the non-thermal effect of modulated electro-hypothermia. And I know this is all in progress and we should use it.
I apologize, I didn't hear the last sentence.
With pleasure. I think, you know, there's a lot of research going on, so I think this can be integrated in future clinical trials to better document the thermal effect and the non-thermal effect of modulated electro-hypothermia.
Yes, I absolutely agree. I think the non-thermal effect is something that's quite fascinating for us.